All right, wonderful. Appreciate it and appreciate the invitation to talk. I do use robotics in my deformity and tumor surgeries. So really my goal today is to give some tips and tricks on how I incorporate robotics and the workflows that I'm using in the operating room. These are my disclosures. So I just want to quickly share my adoption to robotics for complex cases. It did not start with tumor surgery. It did not start with deformity cases. I started with small cases. And you have to remember that as you work in complex cases, even if that's your primary practice, it is helpful to incorporate robotics first within a team environment so that you understand all the pitfalls and everybody understands exactly what they need to be doing so that you can be most efficient in complex cases. All these cases I've used robotics for. The top left panels, you can see this is a patient I had to do a revision on who had a prior Harrington rod. So fusion mass region, that's a helpful place to use robotics. If you're going to use it for scoliotic patients, maybe they have difficult pedicles to cannulate, that's helpful. Distal fixation, multiple points of distal fixation, I'm going to comment on that, and obviously others. So it's a way to improve the pain points that you may have for these more complex cases. This is simply a list of when I think about the advantages of robotics in general, and I know we're hearing about a lot of the different advantages throughout different specialties and applications today. But when I think about deformity and tumor, sometimes I need to really think about the UIV selection and making sure that a patient doesn't have a failure because of their bone quality or prior radiation. And so I want to make sure I spare the facets. I may want to make an incision that's smaller and do a transfascial screw. I could do that with robotics. I can use a larger screw if that's needed because I'm putting a lot of stress in an area if I'm doing an en bloc resection. I'm going to spend some points on pelvic fixation because it's something that's important in deformity, and I'll show you the four options that I use. And obviously, abnormal anatomy is something that's super useful. So when you look at a case like this is a patient who I offered a T9 to the ilium, and I've highlighted here sort of the region that I would normally expose if I was doing open freehand, which I've done plenty of before I introduced robotics. Now with robotics, that incision and what I actually have to dissect is going to be smaller. And so at the top, in a case like this, and you'll see it in the video, I've spared the proximal tissue, and I'm simply showing the rod so you can see the length of the construct and sort of how it relates to the size of the incision. But if I zoom in closer into the image here, you can see I don't have to dissect that entire region where in this case I used an S2AI screw. I can spare that distal dissection. That takes time. If you think about time, blood loss, small gains for big cases make a big difference. And you can see on the right side of the image, I've gone transfascial to spare that proximal tissue, which maybe could have an impact on my adjacent segment disease or failure. Also, in the upper instrumented vertebra, for these cases, not only am I sparing tissue, but I'm choosing the optimal screw trajectory. For me, often I may actually point that screw down, and some people feel like that is advantageous to prevent PJK and stress. So when we think about pelvic fixation, I think about it in these sort of four options. And so I may just put two screws distally. I commonly will place S2AI screws. I know surgeons out there that still use iliac fixation, which is fine, and they don't use it S2AI simply because they find it more cumbersome. That's much less cumbersome with a robot. What if you want to put 4 points of fixation, but you don't want to use maybe 4 rods? You can do that. You can plan to put them in line, and I'll show a case of that. This next case, sometimes I'll actually put 3 points of fixation whenever I'm doing a kickstand screw or what I'll call hemipelvis distraction, and I'll put those up front. And putting 4 points of fixation actually becomes much simpler, and you can work around the pain points if you're planning it before you place the screws with a robot. So case like this, where you're putting two in line, this is what it looks like on the planning software. And you can see that the planning software doesn't have a head on the second S2AI screw because this is not something that was worked into the software for this particular company, but you can plan it and it works really well. I mentioned the hemipelvis distraction or the kickstand screw. Oftentimes, when I first started doing hemipelvis distraction, I would wait till the end of the case to understand. We now know what those parameters look like for deformity cases. A case like this, who has maybe a 7 centimeter coronal imbalance, if I lay her supine and it doesn't correct to less than 4 centimeters, it's very likely that with all my techniques, like this case, an ALIF, and maybe even doing a posterior column osteotomy and a bow type C, I'm not going to be able to correct that fractional curve enough to get an optimal correction. And so I need hemipelvis distraction. But let's say that when I put the first two rods in a case like this, I actually get the optimal correction. Then I'll simply use that screw and that additional rod as an accessory rod. And so this is a nice way to just right up front plan for that screw, optimize your S2AI trajectory so that you can fit that screw in additionally, and robotic helps with that. Okay, you can see what I'm doing here for these cases. She's coronally off to the left. You can see her spine and that angle to the pelvis, and I'm actually distracting the pelvis through that screw, really taking most of the stress and pushing that ilium down to get the coronal correction that's needed. When we used to freehand 4 screws into the ilium, I would often try to picture and imagine in my mind where those screws need to converge. And then I would often use a ball tip pointer probe and hope that those screws wouldn't collide when I was putting in that second screw, that they wouldn't kiss or touch. But you can see here, I can easily plan for that and it's not an issue. What about what we're seeing more now these days is that patients, when they come in, they have sometimes SI fusion implants. What do you do about that? Well, once again, if you use robotics, you can easily understand if there is even a corridor at all or not. So I'll use robotics even just to plan and understand. For this case in particular, on one side, I was able to go around the implants. On the other side, there was no corridor. So I actually just drilled out the implant and then put a screw through that space. These cases, when we think about tumor surgery, there are some cases that are very, very challenging, I feel like. In particular, a sacral chordoma. These are cases where if it's a primary sacral chordoma, this 15 centimeters tumor that I encountered, you have to do an en bloc resection. These are incredibly orchestrated operations with multiple type of specialty surgeons. I need a vascular surgeon. I need a plastic surgeon for a flap reconstruction. We need to do a colorectal surgeon to do a diversion. But when we do these cases, I don't want to worry about the screws. I mean, and on top of that, the reconstruction that you have to do has to be quite significant because it's going to be, you're disconnecting the axial spine essentially from the legs. And so here's a place where I feel like you really want to be thoughtful and plan out your screws. It's not the crux of the case, but it's a very critical portion of the case. Taking the tumor out in one piece certainly is much more taxing, I would say. So for me, it takes a huge load off my shoulders if I can plan a reconstruction like this and use robotics to navigate around that. What about when you have to do a revision? It's very common that probably for deformity surgeons out there, that more than 50% of their practice is fixing other people's work. So when you're encountering a case like this, you're always going to review the prior work and you might say, I need to redirect a screw. That often without navigation or robotics can be challenging. And so for a case like this that has a screw that's low and medial, you can see the tract here, I'll go ahead and plan around that. And when you have a guided system with a robot that you can go in and do a tap through that entire corridor, you actually have a high success rate of going around that prior hole. You can see here the post-op films for that, where we've been able to move the screw that was medial and low and then bring it up and actually put it into the appropriate location. Pedicle subtraction osteotomies, it is to some degree a workhorse for your fused spine, especially if you have a fused lower lumbar spine where you're trying to get correction. In this case, I'm trying to get a 15-degree correction through L4. And one of the things that some of us do is if you're working with another surgeon, whether it's an attending, a resident, or a fellow, you often want to be able to be working together. So although they have to remove bone on their respective side, if you have a case where you're moving through and there's a significant amount of blood loss and you're taking your time per se at the PSO site, it's helpful to be able to suction for the opposite side. And so one of the things that I do is right up front, I'll put my fixation, but at the PSO site, I'll actually use the robotic system to drill and tap screws per se that would essentially meet. I'm not putting in a screw. I'm simply coring out a corridor that will communicate from one side to the next. So you can see here, I've planned screw trajectories, but they're quote unquote colliding, and that's exactly what I want. So I used an 8.5, 60, and 65 tap essentially to go down this corridor. And what you can see here in the video, you can see on the right here, there's that you have L4, you have a block of bone, and you'll see me put in a hemostatic agent that basically communicates with the opposite side. So I'm putting in a hemostatic agent up front. I'm not going to do my PSO right now. At this stage, I simply have tapped the corridor. I'm going to put bone wax. I'm going to leave that hemostatic agent in. And then when I'm working with my co-surgeon, we're operating at the same exact portion of that L4 level. And then I'm suctioning for him if it's needed, if they're having some issues on the opposite side or vice versa. So it's actually a very helpful, I feel like, tool and technique. And by the time you get to the PSO, because the hemostatic agent has been in there, it actually behaves a lot better from a blood loss perspective. That's the results from this case. Every now and then when you do tumor surgery, you will encounter cases that you might have not done electively. So I have a strict BMI cutoff of 35 for my elective practice, but this is a patient that came in profoundly myelopathic with a meningioma, intradural meningioma. I'll tell you that when you're doing a high BMI case like this, you want to make sure and you localize the level well. Oftentimes for tumor surgery in the past, what I would do is I would have the radiologist place a fiducial screw pre-surgery day so that I can go down and find the fiducial screw if it's in a region where localization may be a challenge. Now that looks different with robotics. So this is a patient, her BMI is greater than 45. I need to localize around the area where that red arrow is. I'm actually going to just use the robotic system to do that. So I plan the screws because for this case, I need to do a pediculectomy to get around the spinal cord. But it's really nice because what ends up happening is I mount the robot on the patient. I've planned my screws before surgery. I do the 2 x-rays for registration, and then I use the robotic system to locate where the screws and basically where the tumor is. I open up the skin, I do transfascial screws, and then I'm simply dissecting down. And now I know exactly where the tumor is, and I've placed a screw in an area where I'm going to do the pediculectomy. So it's already done part of the work for me. So it makes a case like this much more streamlined. So the workflow, as I mentioned, 2 x-rays for registration, transfascial screw placement, and now the screws are my landmark for where the tumor is essentially. And so transfascial, what I'm referring to here, this is where you just make a skin incision, you dissect quickly over the fascia. And this is the perspective from the right side. There's cranials to the right, caudals to the left. And you can see I'm going through incising the fascia, placing my cannula. And through the cannula, I'm going to use the surgical tap. And then through the tap, the system that I end up using is just a modular system where I just put shanks in, and that makes the exposure much easier because I'm not taking x-rays to find out where I am in the spine. I'm simply finding the screws, and they're already placed by the time I go to do my surgery. You can see here in particular in my setting, when I'm working with a resident, I find it very valuable for education. Because what I often do is I'll tell the resident, the pedicle is essentially your field goal post. So if I'm going to do an on-block PCO, which is what I often will do for these cases, I'll show them where the pars is, and we'll just drill from side to side with the pars, and then we'll remove that segment of bone. So you can see I'm doing that here. So once again, I'm going to remove that entire section. I'm drilling where that yellow line is. So we're drilling across side by side, 2 drills at the same time, and we know exactly where to go and where we shouldn't go because the pedicles are marking that location. And to me, I wouldn't have done this if it wasn't for robotics. I usually would do this first and then place my screws if I wasn't using a robot. And so here we're just removing that entire block of bone that will be used for bone fusion, and it's particularly helpful to do an en-bloc PCO when you have to work on a degenerative patient and you have to open up the canal for a laminectomy. So once again, robotics being used here for modular applications, using the preoperative CT to place the screws up front. And then you can see these are the 3 different levels we did an en-bloc PCO. And then at the final stages, I simply just place on the heads. So what about when open lag marks are non-existent? I showed the initial set of many cases on one of the first slides where I did that for a Harrington rod. This is an achondroplastic patient. Once again, similar to a tumor surgery that I mentioned earlier, this is going to be a difficult case. If you look at that bottom right-hand corner, this person has had multiple surgeries, non-instrumented in an outside country. And so you can see pedicle fixation may be challenging, but that for this case was not, because I used the robot. And so here I'm doing a 3-level vertebrectomy, making sure that because I need optimal screw fixation above and below, and it's going through smaller and more difficult corridors, I have them all planned out and I've been thoughtful before the case. And so you can see here screw trajectories optimized, very medial, and in a corridor that's very small. So you can see here she's had a good realignment. I'm showing the T4 and L1PA for her 3-level vertebrectomy. As you know, with robotics, your implants are already selected. That's often, this is what my room would look like a few years back. And then now that we use the modular system and we have all the screws labeled out for these cases before in the heads, everything sits on a tray. And so it ends up being much more seamless for the scrub tech. And they really like doing that system in that way. So I'll just end there. In conclusion, I would say that the robot has certainly helped me tremendously, in particular on the ends of the construct. That's why I spent some time on the pelvic fixation. I used that basically for every deformity case. I think about the applications when it comes to tumor and deformity as what are the pain points? What are the workflow areas where the robot can help me? And you can see how I've sort of thought outside of the box when we've talked about the PSO and even localization. And then you can really focus for these cases on the part that is more the crux of the case, which may be the correction, the osteotomy, or the tumor removal. Thank you.